right. All right. I am back. Everybody hearing me?
Yes, sir.
Yes, sir.
Yes, sir.
Everybody can see me on cam?
Yes,
Am I
sir.
visible? Okay. All right. So for this portion of the session, my son is going to assist me again. We're going to look at upper extremity splinting. All right. Now, before we go to the splint, just quickly, I'm going to demonstrate how I would wrap a sprain. So let's say he had a sprained wrist. I'll show you how I would wrap that. Right, now once I have enough around the wrist, I'm not gonna make it too big because you still want mobility, right? So once I have enough, I would cut and tape. That's how I secure a wrist. Now, so I start from the hand, then come down to the wrist and ensure that it is properly supported. We don't want to make it too tight to the point that it cuts off circulation. Now, the same way in which I wrap the wrist is the same way I would wrap the ankle. So I would start around the foot first, then I go around the ankle. All right, so that's wrist. Let me show you the elbow. All right. And I hope you guys note that I am still in my work clothes, you know. I came straight from work. All right. Now, if it's the elbow, turn sideways, slightly, turn this way. Right. So hold the hand up here. So if I'm gonna wrap a elbow, sprain elbow, this is how I would do it. So I would start below the elbow, secure that. Then I would go above the elbow. Then I would go in the middle. Then below the elbow again. Then above the elbow. Then in the middle again, right? So I don't want it to be that the patient, when I finish, the patient can flex or extend the arm, right? That's how I would secure the elbow. All right, now let's get to the splinting. All right, so there's a possible forearm fracture. Support the limb. Can you use your other hand and support it? So there's a possible forearm fracture, right? Right here. Now you can use two splints. You can use two splints, or you can use one splint, right? I prefer one. So you won't see me using two splints for a forearm fracture. I don't want too much compression on the limb. You want, anytime you're using rigid splints, you always use the padded side. padded side of the splint. This would be the rigid side. Rigid, padded, right? So the padded side, the splint is what you want to use. If you're using a makeshift splint, like you're improvising or using board or something that's very rigid and might be uncomfortable for the skin, take a bandage and wrap that board to get some padding. All right, now following the principles, the first thing that we need to do is what? Miss Johnson, what I need to do first?
Check the pulse above and below. Sorry,
Right?
check the pulse. Yes.
Pulse, just pulse.
Sir, check
Or,
PMS.
okay. What about gloves and manual stabilization? That's a question.
Yes, sir. That is the first thing we think about, sir.
Okay. Miss Nesbeth, what do I need to do first?
After PPE, sir, you have to visualize the limb to see where exactly the injury is. So you feel it, sir, just to using DCAT BTLS and noting whether or not you're feeling any swelling or any abnormality in the limb.
Okay. You feel it if there is no obvious deformity. All right, so you take standard precautions, you visualize the limb, you look for signs of a musculoskeletal injury using a DCAP BTLS. Once you know that an injury is present, you give your partner instructions. Partner, I want you to manually stabilize the limb. Now, if I had a partner working with, this is how my partner would manually stabilize the limb. So my partner would hold the elbow and the wrist. Now, note how and where I hold the wrist. Make sure to note that I didn't do this. I did that, right? So as the partner, I am aware that my partner is going to need access to the pulse. So I'm not covering the pulse, right? All right, so that would be manual stabilization. Once my partner does that, then I will check the radial pulse, and I'm going to do that bilaterally, right? So bilateral radial pulse. Then I will give the patient 2 fingers, squeeze my fingers, release, good. Then I'll give the patient instruction, hold your hands high up that they can see what's happening. I would tell him to close his eyes, close your eyes. Which finger am I touching? Answer me. Which finger this? Which one of your fingers am I touching, Kani? Good. You feel the same thing on this side? Feel the same? All right, so that's pulse, motor, and sensory function. The next phase is if he has a good grip, I will give him something to grip. Hold that for me. Then padded portion of the splint, support the splint, good, right? Then we will use either roller bandages or triangular bandages to secure. So you tie, ensure that you have equal length on both sides, overlap, pull. Is that too tight? You can't open your eyes now, you know. Is that too tight? Okay. Then you do what is called a reef knot. which is right over left, under, then left over right, under. So that's a reef knot, right? Tuck away the edges. So I'm securing above and below the injury site. Equal length, both sides, overlap. Right over left, under, left over right, under. Right now, as you can see, the patient can still move the limb. So I need to restrict this motion. Now this is where a sling supported canal. A sling, sit up, you're not sitting up. Sit up, good. Make sure that is visible. So this is where a sling will become necessary. So this is your triangular bandage, right? It has an apex, and the longest side is the base of the triangular bandage. The apex is going to line up with the patient's elbow. So the apex is lined with the elbow. Right, you can rest that against the chest. Right? And you tie it off at the back, tie it to one side. Same reef knot. Right over left, under, left over right, under. Right? Now stand up that they can see. Everybody see what that looks like? So this is a sling. Yes?
Yes, sir.
Yes, sir.
All right. Good. Now the patient is still able to do that with the limb. So I need to restrict that movement as well. And this is where the sweat will come into play. Now I want to support the limb, so I'm going to come across the humerus, and right where the wrist is, provide support here. Then tie it at the back. All right, now it's fully secured. Once it's fully secured, I will reach back under, check my pulse, make sure the pulse is still there. Pulse is still there. Open and close the fingers for me. Open and close. Open and close the fingers. Open and close. Good. Close your eyes. Still feel the same on both sides? Yes. All right. Now, stand up. So that's what that would look like. So that's the stabilization of a possible forearm fracture. Any questions? Yes, Mr. Jennings.
Sir,
Yeah.
I think you should show us how to do the twirly thingy with the apex to neaten it up on the side of the elbow. The twirly thingy, you know, when you twirl it to stick it away so that it don't hang off.
Stand up. Turn this way. So all I'm doing is just twisting it, right? That's all I'm doing. Some people will make a knot, I twist, right? That's it. Any other question?
No, sir.
Okay. All right, now the same thing that they pull it up, same thing that the triangular bandages do, a roller bandage could do the same. So instead of using the triangular bandage to secure the splint, I could use a roller bandage to secure that. I'm going to show you what that looks like. All right, so support it again, you can hear. Better yet. Switch position. Put this in this hand. All right, good. Preferably bandage, so do not use an elastic bandage for this purpose. So you would have done your standard precautions just like before. Expose, look for obvious signs of a musculoskeletal injury. Give you the instructions to manually stabilize above and below, manually. Check pulse, motor, and sensory bilaterally. Apply splint, give the patient something to grip once they have good motor function. Then you will bandage distal to proximal. Now when I get to where the fracture is, I'm going to keep that portion loose. And the reason for that is simple. I'm anticipating swelling, right? I don't want a lot of compression on the fracture. When I get close to the elbow, I start to tighten the bandage, right? Cut and secure, right? Put it in the sling. Once you're finished, you need to ensure that you still have access to the pulse, which I still do, right? So that's a faster way to secure the splint. But you have to learn the hard way first. All right. Now let's look at the elbow. Now you can use one splint for the elbow. If you're going to use one splint for the elbow, instead of stabilizing the arm this way, you would stabilize it this way. So you put it like that, right angle position, right? So it needs to be at a right angle, like that. You would use a roller bandage to secure the forearm to the splint. Then you put it in a sling and you do a swing across the humerus, straight across to secure the humerus. So you would be securing the humerus and the radius and ulna. This is the injury point. So we're securing the bone below, bone above. So that's one splint for the elbow. If you're going to use two splints, which is my preferred method, patient has the arm, so support it like that. Make sure they can see it. Sit up. Right? So the patient has the arm like that. You take standard precautions. That's the first thing. You need to visualize the limb. So if it was exposed, you ask permission, cut, expose. Look for obvious signs of musculoskeletal injury, right? Decap, BTLS, instability, crepitation. There is obvious deformity in the elbow region. You instruct your partner to manually stabilize the limb. Now, if I was the partner, this is how I would manually stabilize the limb. So note where I am stabilizing. I'm holding the radius and ulna and the humerus, right? Support it again. Now, once my partner does that, just like before, check the pulse, radial pulse, squeeze my fingers, close your eyes, release my fingers. Which finger am I touching? Feel the same on both sides?
Yes.
All right. If the patient has a good grip, hold that for me, right? Then you will put one splint below, like that, one splint like this. So stand up that they can see what I'm doing. So just stand up, stand up. So you're putting one splint here and the other one on top like that, right? That's what you're doing with the splint. Sit, support, so hold the splints. Hold the splints like this. Go. Then you will prepare your triangular bandage. And what I'm going to do is use one of the bandage to catch the humerus. Not too tight. So when them say that, you have to get up, Connie. You can't stay. They won't be able to see it like that. All right, so that's one. Sit. Then you will use another triangular bandage to catch the radius and ulna. Equal distance, overlap. Talk to your patient. Is that too tight? Then reef knot, right over left, under, left over right, under. So stand up, let them stand. So that's what it will look like. Now, who can tell me what I would do next? Miss Nesbeth, what would I need to do next?
Check the PMS, sir.
The patient still can do that. So what I need to do about that?
Oh, okay, yes, sir. You're going to be preventing anything that you use. Can you still use a swab, sir?
Sling and swing, yes. So that would be next. Sling, swing. After the sling and swing, what's next? Jennings. So after we put it in a sling and swing, what would be next?
So you put it in your sling and you want to recheck the PMS bilaterally. So make sure that you have good circulation, good sensation, good motor function.
Right, we're gonna check PMS. I don't think the pronunciation is what. But anyway, Some people say that. So you put it in a sling just like before. Yes, Mr. Jennings.
So, sir, you wouldn't lift the arm, the hand to the shoulder?
No, it's an elbow. You can't do that. It's an elbow injury. You have to keep it low. You try to bring it up like that, it's gonna hurt. Trust me.
Okay, sir. Thanks.
Right? So if it's an elbow or a shoulder issue, you keep it low. If it's a forearm, that's fine. That is fine. What we want for the elbow is a right angle. So stand up, Kenny. And if you can just keep it like that. If you can look, you can see that there is a right angle here. Right? That's what you want. You want that right angle. That's the position of function. Now, with the weight, instead of going here, you go across. So going across would be fine. If you decide to go across on the splint, that would be okay as well. We just don't want to create any discomfort. Sorry. We don't want to create any discomfort in this area. So you can go straight across like that. You can go at an angle and catch this portion, which is fine, right? That's fine. We don't want any unnecessary pressure in this area. All right. Now, after we sling, put it in a sling and swathe, what would we do at this point? I think somebody said it. We would reevaluate pulse, motor, and sensory function. Somebody did say that. Any questions? So that's our elbow.
Sir,
Yeah.
what if you weren't getting the pulse upon palpating for the first, sir? Before you put on the sling, first PMS, suppose you weren't getting pulse nor sensation, sir?
I don't understand what you're saying.
Suppose the elbow is compressing the blood vessels in the area. Would you attempt traction, sir?
I already explained when I would attempt realignment. I don't think I need to explain that again. I've said to you guys before, the only time we will attempt realignment of a limb is if there is absence of pulse, motor, and sensory function, right? And the distance to the most appropriate facility is not feasible for the limb, meaning it will take us too long to reach that hospital if we don't do something. That's the only situation I would consider to realign a limb, especially a dislocation.
Sir, probably my question wasn't specific enough. I know what you said and I understand all that you said before and what you said now. But the actual realignment of it, so suppose you are not going to reach hospital until the next hour and realignment of the limb becomes necessary based on your consultation with medical control. Is there a particular way how to realign a limb or just force it?
I'm not gonna tell you there is a particular way, and I'm not gonna demonstrate that. You would be guided by your medical director. Every protocol is gonna be different in that regard. There's no set way to do it, right? So to realign the limb, there are different ways you can do it. I will not teach you that at this stage. you're going to be guided by your medical director, right? So realignment can come from you positioning the limb for stabilization, right? I have a patient that had a dislocated shoulder, and when I was putting the arm or limb in position for it to destabilize, it popped back in, right? There are other ways to put back the shoulder in place than doing that. You can actually hold pressure underneath the arm and pull it back into alignment. Same thing with, so there are too many methods for me to say, use this, right? If it's something that your protocol will allow, your medical director is going to guide you. In some cases, the medical director might say, no, wait until ALS arrive that the patient can get medication, because some of these dislocation hurt severely, where the patient might need meds before you attempt realignment. So it's a complicated situation to explain with one specific function. Sorry, explain with one specific task. It's too complicated to just say do this. All right, so that was elbow, forearm. Shoulder is simple. So if it's a shoulder dislocation or a shoulder injury, all you do is put the extremity in a sling and swing. That's it. The only variation or only thing that might be different is, you would put some padding between the patient and the injured limb. So you're gonna put padding, whether it's a blanket or a pillow or a towel, you put padding between the patient and the limb, because when they bring it in like that, when it comes in, it hurts. So you're gonna find them doing that with it away from the body, so we want to keep it away. So that's shoulder. For the humerus, there I've seen persons do two, stand up again. So for the humerus, you want to be able to secure shoulder and the elbow, right? Now, one of the ways to do that, so I think I probably need to demonstrate this one. All right, so the patient has a fractured humerus. Now, this is a bone that if fractured, the muscles around it will contract and pull that bone in, right? So you may be required to apply manual traction, where I'm holding the joint here and joint up here, and I'm pulling the bone, pulling it out, right? So that it don't compress the nerves and blood vessels, and you use the uninjured limb to gauge it, right? Because when the bone is pulled out, this limb gets shorter than the uninjured one. Patient is going to be in a lot of pain if they're responsive. As soon as you start to pull it out, the pain decreases. Now, once that is pulled out, it must be maintained, right? So that would be manual stabilization. So it's not just manual stabilization anymore. It's manual stabilization with manual traction. So whoever is holding that area need to maintain traction. If they release it, then you're gonna get a slingshot effect, right? Once it's released, the muscles will pull it back. We don't want that to happen. Support. Right, so once your partner does that, just like before, standard PPE, look at the injured limb, look for signs of obvious trauma, musculoskeletal injuries, decap, BTLS, you note obvious signs of that. Instruct your partner to manually stabilize the limb. Partner does that, then apply traction. And when you're going to do that, so I need to align your limb. I need to get this bone out, right? It's going to hurt. But what I want you to do for me is take a deep breath, right? Take a deep breath in and breathe slowly, right? So I want you to take a deep breath in and exhale slowly. Deep breath in. Tell me when it doesn't hurt and you maintain that, right? Once you have manual traction and manual stabilization, you know the rest. Check pulse, motor, function, sensation bilaterally, right? Now, the first thing I'm going to do is I need to catch this limb in a sling. Again, elbow, elbow in line with apex. Bring it back against the body, support it at your limb. So I need to catch it in a sling. That's the first thing. And this is just one method. So there are other ways to stabilize a humerus. Many other ways, depending on the type of splints that you have. And you could use a flexible splint if you had one. So that's the first thing that we do, right? So stand up that against that. Put it in a sling. Part one, sit back down. Then I will take a padded splint and I'm going to put it on the outside, right? Support the splint. Support. I want you to just keep it there until I hold on out. Slide this under your arm. Then I'm going to use a sweep to secure the upper joint, which is the shoulder joint. Then I will use a sweep to secure the one there. So this. All right, you can move your hand. Move your hand. For the elbow joint. Don't make it too tight. We just want to keep the splint in place. All right, stand up. So that's what that would look like. So that's a humerus. Once you finish, you go back to your pulse, motor function, sensation. All right, stand up again, let them see. And as I said, this is one method. You could actually use this bandage and secure the shoulder joint directly to the splint. You could also use this bandage and secure the elbow. Either way can work. As long as at the end of the day, you stabilize above and below the injury site. Any questions? So that's a yours. Yes, Janet.
Yeah, in the event that you need traction, how does this maintain that?
Sorry?
In the event that you need that constant traction from your partner, how
Remember,
does this?
if a bone is fractured and muscles are around that bone, so this is a bone, naturally, right? If there is a fracture and muscles are around it, it pull it like that. Now, if it is pulled out like that and I pull it out here and I put something that's rigid on this side and this side, wouldn't it keep it in place? There's no room for it to shift. So that's how the splint is gonna hold the bone where it is. That's how you do it. You're maintaining tension on the area so that the bone doesn't slip back out. That's the principle of splinting. Same thing like what a traction splint does. Yes, Miss Johnson.
Sir, so that means that the partner would have to hold the tension while you put the
Right,
sling? Okay.
right. So while you are preparing the sling, which is the first part, your partner would have to maintain that tension because you need to get the sling tight enough that it's holding it, right? So the partner is going to maintain that tension, and once the outside splint is applied, the tension needs to be maintained. Yeah. Yes. Go ahead, Miss
So,
Johnson.
sir, just like how with the fracture in the forearm
Mhm.
where the splint was put first, the splint can go on first on the humerus, sir. Cause what the splint if you stabilize if you use a splint to
No,
stabilize.
not for
Okay.
the because it's a fracture where the bone has been pulled in, right? So some type of manual traction must be there first. And the only way you're gonna put that, so hold on there, give me this side. So let's say this is the limb that is injured. Now, if you decide that you're going to be tying just the joints, right? Let's say you're focusing on just tying the joints when you secure. Your partner have manual traction, you put your splint and you secure, that's fine, right? That's fine. If you're going that way, that is okay. That can work. Is that what you were saying?
Yes, sir. Because what I'm thinking is I was trying to figure out how is it that the partner is going to hold the traction while the splint is in place and if it's not going to snap back into
That's
the
not
the
difficult. That ain't something difficult, right? And when I have you in a live session, I can show you that very easily. Right now, whether you secure this way or secure straight across, tension must be maintained, right? So I cannot release this tension until something is creating tension in the area. Same thing with this side. I can't release until something is creating that tension. As the bone is going to be pulled back in. Same thing can happen with the femur. So if there's a femur mid-shaft fracture, anytime it's the shaft, you need to anticipate muscle contraction, pulling bones in. With the femur is the same concept. Whoever is holding manual traction cannot release it until a device is creating that traction. Then you can release. But it can be done. It's not difficult. It ain't difficult. All right. Now, the only thing that remains is clavicle. So we have looked at forearm, elbow, humerus, shoulder. The only thing that remains is the clavicle, right? So if it's a forearm, you can use 1 or 2 splints. This would be the position of function. Anytime you're going to stabilize, you always try to get back the position of function, right? And your point of stabilization is wrist, elbow. If it is misaligned, meaning shaft, break, and it twists, then you have to realign it. If it is the elbow, you can use 1 splint. And if it's 1 splint, hammer fist position would be considered position of function. You're using 2 splints, then you still have it in the hammer fist position, but there's 1 splint under and over, right? And you secure the radius and ulna and the humerus. If it is the humerus and there is tension in the area where the bone has been pulled in, manual traction must be applied. And whichever method you're comfortable with splinting, you use that method. You can go triangular bandage to hold tension where the triangular bandage is on and it is tight and hold tension in the area. Then you put your splint, swat below, sweep below, sweep above, right? That would be humerus. Shoulder, all you need is a sling and a wide sweep, and you ensure that you put padding between the patient and injured limb. The clavicle is straightforward, right? So if it's a clavicular fracture, all you need to do is put the limb in a sling and use a sweep to control it. But you want a high sling, right? So this is how you want that arm. It should be as if the patient is touching the opposite shoulder. You want to make that sling very tight and secure, right? So that, and if you do that, if you take your arm right now and bring it across the shoulder like this, you're gonna feel that this area feels much tighter. You can feel that coming in, and that's what we want. We want to keep that clavicle in, right? So that's all it would do for the clavicular fracture. That is your upper extremity fractures. Those are the variations that you need to be familiar with. It is not set in stone, right? So you go out there and you have a patient with a dislocated elbow. You find the patient have the arm like this, right? It can be that you at that point say, okay, sir, never teach me how to stabilize it if the arm is like that, right? Now, yes, you will try and get it in the position of function. If there is too much pain, how am I going to stabilize that? If the patient can bring the limb here, how would I stabilize it if it's like this? That's a question.
Would you just tie it to the body?
Right. You could simply secure it to the patient's body, right? So just understand the principles. Nothing that I've showed you is cut in stone. There are various ways to splint. You just need to understand the fundamental principles. That is what is important, right? So don't try and swat what you see on the video. Understand the principles. That is what is important. All right, any questions? Yes, Miss Johnson.
Sir,
Yes.
sir, so when the clavicle is fractured, and the hand is placed to touch the opposite shoulder. If you put it in a sling, so the elbow is what is going to. I'm trying to visualize it
Visualize.
because if I'm trying to visualize how the triangular bandage is going to be placed, so that the
Yes. So this is where the fracture is. Right?
yes,
Good. If this is the clavicle that's fractured, what I'm doing is I'm locking this in place. The triangular bandage locks all of this in place. If all of this is locked in place, there is limited movement here. That's what you want, right? If I have a fracture here and I keep doing that with my limb, what is going to happen to the bones here? It's going to keep separating. So the goal is to keep stability in the area. The best way to do that is a high sling, because when you do this, when you bring your arms up like this, the bicep muscle contracts, right? So all of this is, there is flexion in this area, and that is keeping this area stable. That is the basic principle of that. That's how you stabilize a clavicle. It's nothing complicated. Any other question? Yes, Jenny.
So, what if you have multiple fractures on the same extremity?
You can answer that question. If you have multiple fracture on the same extremity, what would be your approach at that point? Are you concerned about the limb or the entire patient?
I mean, you're still concerned about the entire patient, but
Good. So what would make more sense? Wouldn't it make more sense to put that patient on a spine board and prevent shifting of that limb with multiple fracture than trying to figure out how I'm going to stabilize multiple fractures in the limb? Would that make more sense?
that would make no sense.
Right. So if there is multiple fracture, you think about the entire patient. And if a patient has multiple fracture, it means that that's a load and go patient. So your objective at that point is to splint the entire patient. And the best way to do that, spine board, right? Spine board. I have had a patient in a motor vehicle accident with a humerus fracture, but to how badly damaged the vehicle was, this was not my priority, right? I did not focus on this. I put the patient on a spine board en route to UE, then I focus on that, right? So again, prioritizing the management. You can't, there's
Okay.
no way you can stabilize multiple trauma in a limb, right? It's too much fractures for you to try and figure out where you're gonna stabilize. So what would make sense? How am I going to minimize shifting of this limb? Use a spine board.
So it is basically thinking about the kinetics of the injury. Because if there
Right,
was a, okay, all right, I
exactly.
understand.
Because if the patient have multiple trauma, it must take significant force. And if you are anticipating significant force, it means it was diffused. That's a diffuse mechanism. So the potential for other serious injuries or the significance of that injury can compromise the core systems within the body. So focus on the entire patient. Quick and fast movement. Reasonable question. Any other questions? All right. You are dismissed. This is mine, don't leave with it.
Thank you, Khalil. You are great.
Thank you. All right. No. All right. Having gone through the principles of stabilizing the upper extremities, right? And looking at the variations in stabilizing the upper extremities. Using those same fundamental principles, if the patient had a tib fib fracture, what would be your points of stabilization, Miss Johnson?
Sir, the points of stabilization would be the ankle and the knee.
Okay, good. And where will you be checking the pulse?
I would check the pulse at the top of the ankle.
Okay.
I don't remember this.
The dorsal speed is not at the top of the ankle. But anyway, I know what you're talking about. It's the dorsal pedis, right? And what we need to do if we find the dorsal pedis, because it's not an easy pulse to find feel. So what would I need to do if I found that pulse, Miss Johnson?
What do I do if I find the pulse?
Yeah, the dorsal pedis
So,
is not an easy pulse to find in the feel, you know.
sir, there is well, sir, that is not the one I was talking about. I was talking about what's the name again? The
Posterior,
one that is nearer to the ankle on the anterior side.
anterior,
On the
posterior.
anterior.
Typical is not anterior, and that is
Oh,
right behind the ankle, right in that groove right there. That's posterior tibial. That would be easier to find, right? I think next week I'll show you on the foot. I don't have the foot close by, but I'll show you, right? Dorsalis pedis would be more anterior, and it's between the big toe and that toe beside the big toe. You're gonna find it in that region, not close to the area, more I would say midpoint. So it's the midpoint of the foot in that region. When you find that pulse in the field, you need to do something and mark the area. If you're able to locate that pulse in the field, take something, mark the area. It's not an easy pulse to find, right? But you are correct. The stabilization points would be ankle and knee. Ms. Nesbeth, if the patient has a knee injury, straight leg. So it's a knee injury, patellar fracture. Where would be your points of stabilization?
It would be on the femur and on the long bone of the tibia slash fibia.
Okay. Back to you, Miss Johnson. How many splints would you use for the tib fib fracture?
how many splints?
Yeah.
Sir, um, sir, you can use one traction splint, sir.
Traction. Hmm. Traction. You sure about
Sorry,
that?
sir. Sorry, sir. The traction is for the femur, sir.
Hmm.
So, for this one, we could use a vacuum splint, sir.
Why I get so technical, man? It's a tib fib fracture. Your company don't have a vacuum splint. What type of splint you gonna use?
Sir, I can use a rigid splint and maybe use two, one on either side.
Okay. All right. Fine. That is okay. You can use one splint, and that's fine for a tib fib, as long as that splint covers um, ankle and knee joint. But two is fine. All right, Miss Nesbitt, with your patella injury straight leg, how many splints?
2 on either side, anterior, lateral and medial.
Okay. All right. Two splints is fine. If you decide to get extra and use three, that's fine as well, as long as you maintain the principles of splinting. But two would be acceptable. Um, Mr. Jennings, your patient has a distal femur fracture. Distal femur fracture. Where would be your points of stabilization?
Questions. All right. If it's a distal femur fracture, it is still the femur. So I would still want to maintain the knee and the pelvis region. Those are my
What
points of
about
stability.
what about below that? You wouldn't want any stability down that side?
Yeah,
Think about it.
I am thinking about it. Like distal would be nearer to the knee, and I would. So
I
what you would
agree
you
with
would
the, I
maybe
agree with
maybe
the
maybe it would be the ankle, because if you maintain it in a straight position, then you could hold the ankle. That would be keeping it the whole leg in a neutral position. That may make
so
sense.
that would be acceptable. You need three anchor points, right? So yes, you need to catch the knee, you need to catch the hip or pelvic area. But if you don't catch the ankle and the patient is able to move that area or there is shifting in that area, a clot can be dislodged, right? It can cause shifting of the fracture. So you'd want to catch ankle, knee, hip. This
3 points.
that's it. Mute your mic, Jenny. Mute your mic. Miss Jackson, your patient have a say patient has a proximal femur fracture. Proximal femur fracture. Where would be your points of um, stabilization? Write that in the chat if you're present. No, while Miss Jackson is writing that in the chat if she's present, what do you guys take from the questions that I just asked and the answers that you gave? What do you notice? Yes, Miss Jennings.
Mr.
Mr.
Jennings.
Jennings, sorry. One.
What I noticed is that the what I would say is the anatomy of the no, not the anatomy. The mechanics of the lower extremity are the same as the upper extremity, or the anatomy too, because you have those two bones.
Right.
So you would use the same splinting principles for the lower extremity as the upper extremity.
Good. So the same principles apply. Similar principles. There is nothing different, right? Same principles. All right, the same principle. So once you understand the principles, you apply the principles. That's it. That is it. Miss Jackson, where's your response, young lady? I'm not seeing it. I am not seeing her response. Anyway, it is what it is. It is what it is. All right. Now there might they I don't want to say variation, but important considerations for lower extremity splinting is because that area of the body is more muscular. You tend to get angulations a lot in that area, right? So you may have to do some inline tractioning. You may have to do a lot of that to stabilize the lower extremities. It might be something that you have to do, and there are some agencies which incorporate a figure of 8 around the foot to prevent flexion and extension of the foot. And that's the principles of splinting. That's it. Are there any questions? Yes, Ms. Nesbitt.
So we're going to do traction splinting another time.
I'm not going to teach traction splinting. So that's not something I'm going to teach. I'm going to teach you how to use a traction splint. It's a useless equipment. Right?
Why you say it's useless, sir?
Because you're not going to find a patient with a mid-shaft fracture without other complications. And traction splint is very specific in when it should be used. It can only be used for isolated femur fractures. You're not going to find a patient in the field with only an isolated femur fracture. So you will probably never ever get the opportunity to use that splint, right? You normally end up using your long splints. Somebody holds traction and you put your long splints there and stabilize the leg. It really serves no purpose right now in EMS, and I think it needs to be removed from the National Registry testing. Yeah. Go ahead, Miss Nesbitt.
Sir, in the trauma assessment video that you sent, you used an air traction splint on
That was a ear traction splint. Yes.
Yeah, that's what it is. That's why I thought you were supposed to know something like that. So don't no air traction splint or nothing like that. Then.
All you need to know is that if a patient has a mid shaft femur fracture, isolated mid shaft, a traction splint is indicated, and you can look at the steps of its use, but it's not something I will test you on. Right? Most of the patients I've had with femur fracture, a spine board, and long splints. That's it. And I don't need a traction splint to create traction. I can use a triangular bandage, 2 triangular bandages, and the stretcher and create traction. So as I said, it's an equipment that it's a fancy equipment that a lot of research did not go into. Right? I've not seen a isolated femur fracture. Maybe others have, but I've not seen it in my 19 years. Yes, Miss Nesbitt.
To provide manual traction in a femur fracture,
Mhm.
the person will use the same ankle each though to draw down the bones.
I'm not hearing it. Come again.
To apply manual traction
Mm-hmm.
in a patient with a suspected femur fracture. Should, so our partner would use the ankle heel to draw down the lower part of the leg, and until the patient doesn't feel the pain, they will still do that and maintain it, and then we use the splints to stabilize the area.
I hear bits and pieces. So I hear ankle hitch to pull the leg. And what?
Then maintaining that position,
Mhm.
then we would at the same time be putting on the long splints and then stabilizing the areas that we need to stabilize, right? So they would
Yep.
use ankle each still, sir.
Yep, that can work. But there are two principles behind doing manual traction. So you putting on a ankle hitch or um, using a triangular bandage to pull the ankle is not sufficient enough, right? It might not be sufficient. So you may have to pull in the elbow, sorry, not the elbow, in the knee region and ankle region. So you can put on the ankle hitch or put on a triangular bandage around the ankle, create that tension, but you also may need to pull the joint area to get that bone out. And you just hold it like that, and your partner applies the splints, right? But it's a very, as I say, it's an equipment that a lot of research didn't go into, and I've just not experienced an isolated femur fracture. Because for you to put it on in the field, the patient really have to be stable. If you don't have a stable patient, you're not going to put that on immediately. You're going to put the patient on a spine board and move. So it's really for a patient that is stable, you would put it on. If the patient initially, I should say, would put it on. The patient is unstable, is spine board, and you move with the patient, right? But it is an equipment that you can read up on, right? Nothing is wrong with that. You can read up on the steps as well. Nothing is wrong with that. Yes, Miss Nesbitt.
Sir, what about the fracture of the pelvis, sir?
That is not for this session. We're doing extremity issues right now. Pelvis comes into multiple trauma, and pelvic fracture is not a difficult fracture to stabilize. What is going to be challenging is how you move the patient. And the easiest way to do that is with a scoop stretcher, scoop backboard. That would be your ideal method. Don't have a scoop backboard, then you're gonna need to lift the patient as a unit, which is risky. But it's not a complicated fracture to deal with. Most important thing is that if you discover a pelvic fracture in the field, once you discover it, you stabilize it. You cannot leave that fracture alone when you find it. You have to stabilize it because it can kill the patient very quickly. Yes, Mr. Jennings.
So I have realized that for the many years A lot of people have been doing the wrong thing.
As it relates to what?
Because you're saying that, okay, the traction splint is only
Right.
used for an isolated mid-shaft fracture. Now, I know
Right.
that, but now you see how you factor in, you're thinking about the force that was applied to the femur and the possibility of only getting a femur fracture like that. Now I thinking, okay, well, what about the patient who had the engine drop on his leg and they put a traction splint on him? Like, that might have been contraindicated because you might have had more fractures if the
Right.
femur was fractured.
And if a femur is in fragments, can you traction it?
No, sir.
All right. So you may be correct then. You may be correct. So, and that is the understanding I want you to have when you go out in the field, right? You need to understand how it is that the skill that I am performing affects the patient. And I think you're starting to get that now. It don't take minimal force to fracture a femur. It takes a lot of force to break a femur, right? So if there's a lot of force applied to that area, it has been transferred somewhere else in the body. And we have to look at the bigger picture, as you're gonna have a leg that looks very pretty in a splint, a traction splint, and a patient in cardiac arrest, right? So it is important to think about the mechanism of injury. And yes, there are a lot of persons out there who are doing the wrong thing or who have done the wrong thing for many years, and the patient has suffered long term as a result of it. So we need to get it right, and that is important. Yes, Miss Nesbitt.
For a patient that has been in a motor vehicle accident and not restrained, and they hit up the knee on the dash, and then that transferred to the femur and actually caused a dislocation of the what's the name of the femur head, like it pushes out of that.
I hit dislocation.
Yes, that is covered. That how would you stabilize that
Entire
patient?
patient. You focus on the entire patient, and with a hip dislocation, if it's isolated, you stabilize it the same way that you would do a proximal femur fracture, right? So you're gonna need, if it's a stable patient, you need a splint going all the way up to the close to the rib cage area. So you want a long splint going all the way up there, so because you need to catch some level of support above the hip and below. So you're thinking about securing above the hip area. That's a definite. You have to secure the knee joint. So you're gonna have to catch the knee. You're gonna have to catch the ankle, right? But it's the same principle as a proximal femur fracture. The only difference is if I suspect proximal, I would secure the hip. So I have to secure hip, knee, and the ankle. If it's the hip, I have to catch the area above the hip. Or if it's a patient that is critical, once you get the patient on the spine board, put some padding between the legs and secure straight across. That's quick and fast. So if you suspect shock, spine board, use a good leg, stabilize a bad leg. That can work as well. That can work, right? So once you suspect multiple trauma is involved, you need to be thinking about the entire patient, right? If you don't suspect multiple trauma, or you suspect focus mechanism, then you think about the injured limb. That's the principles. As I say, EMS is it's not complicated. It's about principles and thinking logical. You got to, and you have to understand your principles to think logical about what it is that you need to do. And for many years, a lot of providers was just doing things because they were told to do it. Right? You're giving oxygen, why? Because I was taught in school that when in doubt, give oxygen. Right? You're creating pressure on a bandage. Why? Because I was taught that I need to create pressure on a bandage. Why? Right? So we need to know why and understand why it is that we're doing what we're doing and how it affects the patient. That's what good patient care is. And it's not specific to EMS. You have doctors that are clueless, you have nurses that are clueless as well, right? Because there were some shortcomings in their education. They didn't get the fundamentals. And anytime you don't grasp fundamentals in any area of clinical medicine, it will affect you when you go out there and treat patients. Because if you don't have fundamentals, you don't understand why it is that you're doing what you're doing, and the patient suffers as a result of it. I still have not seen anything from Miss Jackson, you know. Anyway, it is what it is. Are there any further questions? Okay. All right. That is it for me today. You guys have videos to sort out. I've received 2 videos from Miss Nesbeth already. I'm awaiting the others. Right? Remember, I want the videos by before the next class. If I don't get it before the next class, do not send it to me because I won't be grading it. Yes, Mr. Jennings.
So I just asked him one more time. Is okay for me to, just like demonstrate it imaginarily. I know that's a word, but act like it's there, but even though it's not really there.
That's fine until we can sort out your hands-on stuff. That's fine.
All right.
That's not a problem, right? But if I don't get it before Tuesday, don't even bother sending it to me. That's an automatic 0, right? And that would be a skill that you have not been approved for. So that's an automatic fail for the course as well, right? So get it sorted out that I can guide you in terms of what you need to fix, if you need to fix anything, right? All right, so that's it. You are free to go.
All right.
Thank you, sir.
All right.